Good evening, everyone, and thank you for joining our webinar, COVID-19 1 Year On, where does the transplant community sit in the fight against the pandemic? I'm a general transplant surgeon from Rome, and I'm also the scientific coordinator for Transplant Live, the ESOT e-learning platform. I'm very pleased to co-chair with my colleague, Francesco Giovinazzo, a liver transplant surgeon from Policlinico Gemelli in Rome too. This webinar is part of the activities organized by the TLJ COVID-19 Workstream, led by ESOT President Professor Papalos, that I greet and thank for joining us as an attendee. This is the sixth of a very successful series started a year ago and aims to provide an update about the current situation in the fight against SARS-CoV-2. Thanks to the excellent panels of speakers, we'll go through the published evidence. We'll assess the overall impact on the management of transplant programs and on the donation and transplantation activities in the Eurotransplant zone. Although an insight from the USA reality will be provided as well, together with important data recently published on JAMA regarding vaccination in immunosuppressive transplanted patients. So I would like to let you know that we will have a Q&A session at the end, and you can submit questions in the Q&A box of your Zoom interface. You can already get familiar with this. At any moment during the webinar, and specifying please the speaker you would like to address the question to. We will address all the questions at the end for time's sake, but without any further delay, I would like now to leave the floor to the panelists and get the webinar started. So Francesco, over to you. Thanks.
Thank you very much, Irene. Thank you, ESOT, and thank you everybody to come to the webinar after a year of COVID-19. And just to not waste time, I will introduce the first speaker, Dr. Pengel. She is the co-director of the Center of Evidence in Transplantation in Oxford, UK, and she will talk about a hot topic that probably we need to know, and his evidence in COVID-19 and transplantation. Please, Liset, go ahead.
Thank you for that introduction. So over the next 9 minutes, I'm going to give you an overview of the emerging evidence regarding COVID-19 and transplantation. I have no conflicts of interest to share, and you can share my presentation. So first, I'll start with some studies that have been published on any type of organ transplantation. There has been a nationwide study from Spain and a prospective multi-center study from the US reporting on large numbers of patients. They report high hospital admission rates of patients that have been affected with COVID-19, high mortality rates. And they also show that immunosuppression is adjusted in many patients. They try to identify a risk factor and consistently found that age is a risk factor of mortality in addition to some other factors. There is also a study from the United Kingdom, from the UK Transplant Registry, and they compared the incidence and mortality in candidates and recipients. And they found that the incidence of COVID-19 was higher among candidates compared to recipients, but then the mortality was far higher in recipients. And again, they found age to be the single factor that was associated with mortality. An analysis from the ERA EDTA included kidney transplant patients from Spain and France. Also reported on a mortality rate of 20%, and again found age to be the risk factor of 28-day mortality. This is a study from France, a nationwide registry study, and they looked at COVID-19 related deaths among recipients and candidates in kidney transplantation. And they found that the COVID-related deaths were similar amongst recipients and candidates. And what they also did, they looked at the heterogeneity in the geographical presentation. And what they found was that inside high viral risk areas, the risk of mortality was similar among recipients and candidates, whilst outside high risk areas, candidates had a fourfold higher risk of mortality compared to recipients. This is a study in liver transplantation, and they use data from 2 large international registries covering about 18 countries. They found high hospitalization rates for a liver transplantation cohort, which they compared with a non-liver transplant cohort, and these are patients that they identified from a hospital site. And even though the hospitalization rates are similar, the ICU admission the ICU admission and the invasive ventilation were significantly higher among the liver transplant patients. Mortality, again, it's consistent with the previous study for liver transplant patients, was 90%, and age was found to be significantly related to mortality in addition to serum creatinine and non-liver cancer. The European Liver Transplant Registry has published several reports. This is a recent report. They found mortality to be 20% among liver transplant patients that were infected with COVID-19. Age over 17 had a negative impact on survival, whereas the use of tacrolimus had a positive impact on survival. One of the other changes that the pandemic has brought about is the delivery of care, and a lot of centers have implemented telemedicine as it allows continued patient care during the pandemic, and has the potential to last well beyond the pandemic as well. So the first study by Delman and colleagues looked at the implementation of a multidisciplinary protocol that includes telemedicine, and they compare outcomes in transplant patients that had a liver transplant before the pandemic and compared those with patients that had a liver transplant during the pandemic. Pre-pandemic, there were 100% in-person visits, and this changed to 45% virtual visits during the pandemic, whilst this had no negative impact on clinical outcomes. Sherman and colleagues looked at how transplantation programs in the USA implemented telemedicine. Pre-COVID-19, the telemedicine utilization rate was low, whilst during the COVID-19 era, telemedicine was often used for transplant evaluations, waitlist management, and in fact, nearly for all centers use it for post-transplant care. And the last study on this slide is from Italy, and they looked at the attitudes toward telemedicine, and this study identified also a few potential problems with telemedicine. So they found that the majority of the liver transplant recipients had a positive attitude towards telemedicine. But because the study was conducted in a rural part of Italy, it meant that transplant recipients typically had lower levels of education and poor access to a network or email. And as a result, about half of the patients could not attend the telemedicine appointment. COVID-19 has also had a huge impact on the patient experience and the perspective of patients. There was a survey among kidney transplant candidates who were candidates on the disease donor waiting list. And they found that 68%, so about 2/3 of the population, would still consent to be transplanted, whereas there was about 1/3 of patients who were unsure or would decline a transplant. And this last group of 32% identified, indicated they had concerns about COVID-19 infection, and they also expressed the need to get assurance from the transplant unit that it was still safe to receive a transplant. The next study is a cross-sectional study in kidney transplant recipients, and they looked at the impact of COVID-19 on psychological well-being and sleep. And they found that about half of the patients perceived high levels of stress, and many perceived insomnia, poor sleep quality, anxiety, and depression. And they also found that high perceived stress was positively correlated with insomnia and poor sleep quality, and an independent predictor of anxiety and depression. The perspectives of living donors was addressed in this last study by Saidi and colleagues. And 28% of donors reported that COVID-19 had changed the way they think about the risks of living donation, and that the decision to donate during the pandemic depends on the medical needs of the candidate and the availability of testing for COVID-19. There have been numerous studies looking at the effects of COVID-19 vaccines in the general population. And typically these trials exclude transplant recipients, and the question remains whether results are generalizable to transplantation patients. Now, Doris Egev is going to speak later about their very important trial that they've done, so I won't comment on that, but there was one other study that was published last week in the journal Transplantation, and they looked at the antibody response in kidney transplant patients and compared that with patients on the waiting list with end-stage kidney disease. And they found that the antibody response that was assessed before the second vaccination was only present in 6% of the kidney transplantations, whereas 87% of the waitlisted patients had an antibody response. And just this last slide to wrap up, to show that there are many studies ongoing currently, all in Europe, that are looking at the immune response in transplantation. So in due course, there will be more evidence that will help with clinical decision making during the pandemic. Thank you.
Thank you very much, Lisette, for the comprehensive overview, and most importantly for sticking on time. I would like now to ask all the attendees to please put their questions for Lisette on the Q&A box, and then we'll address them at the end. I would like to invite now our second speaker, Serge Vogelar, the Medical Director of Eurotransplant. I would like also to say hello to the General Director of Eurotransplant, Peter Branger, who is joining us for the discussion as well. Serge Vogelar was trained as a medical doctor at the University of Amsterdam, and after his studies, he was trained as an occupational health doctor. Since 2008, he has been working at Eurotransplant, and he started as manager allocation, responsible for the management of the primary processes, allocation and waiting list management of Eurotransplant. Since 2020, he holds the position of medical director. So he will report on an overview of the overall transplant activity in the Eurotransplant zone. Thank you. Are you on mute mode? Yes.
This is better. Thank you for the introduction. And as the previous speaker, I only have 9 minutes, 8 minutes and 30 seconds right now, because I was on mute, to give you an overview of the donation and transplant activity in Eurotransplant. And for that, I would like to start showing you our fact sheet 2020, which gives you a summary of the activities of Eurotransplant. And you see that last year we had just about over 1,830 donors used for organ transplantation. 6,350 organs were transplanted, and about 5,500 patients were transplanted. On the right side, you see the different organs, which gives you an idea on how many organs were transplanted last year. I will use this fact sheet to make a comparison to 2019, so you can see what a possible impact of COVID could have been on the donation transplantation side. And here you see the highlights. Actually, we had a drop of about 6% of registrations on our waiting list, where there was a slight increase on our active waiting list. Of course, we had but we had a drop of 10% of donation, where there was also a drop of about 9% of transplanted recipients, and the same goes for the transplanted organs. Remarkably, or not remarkably, but in fact, we had a drop of 20% in registrations of living donation, which is actually pretty good explainable, since there were many countries during the during COVID where the living programs were closed. Let's start with our process with registration on the waiting list and the patients on the active waiting list. As I explained, just it was -6%. Registrations, and there was a slight increase, which you can which can be explained due to the fact that many hospitals during the COVID were actually hampered by lockdown measurements, where patients were not easily could not easily access normal hospital care, and this could be an explanation for the drop on the waiting list. As well, as you see, we have a drop of transplantations. This could have been the effect, caused the effect of a slight increase of the active waiting list. Also interesting on the waiting list, not only the registrations but also the mortality on the waiting list. And if you look through this, if you look to this graph, this is actually an overview of the different organs in 2020 on mortality on a waiting list of all countries in Eurotransplant. It's reported by month. You see immediately that in March and April and in May, we had huge increases of mortality on the waiting list, and also in October and November. And you would immediately say, oh, that's the effect of COVID. But if you look a little bit further back to 2019, actually you see for kidney and liver more or less the same peaks that we had in early 19 as we had in 2020. So if it's immediate related to COVID, I think so, but nevertheless we had a similar trend in 2019. If we go to the donation, actually we had 10% less donors less used. And if we look to the distribution of the different countries, you see that there were some countries who had a significant increase of donation. We had also some countries who had an increase of donors. This is a graph which shows you the deceased donors reported to Eurotransplant by month, and what you see is that in the early months of 2020, the green line is 19, the orange line is 2020. You see that the first 3 months of 2020 actually were not bad. They were actually better than 2019. As soon as in March 2020 COVID arrived in Eurotransplant, you see that the numbers drop, and you see especially you see also the dip in October and November, which we now know as the start of the second wave. However, if you look to a long year donation, a long year donation, numbers of donation, you see actually that in some countries already a drop in donation started. What you see here is the donors used per million population by country, and you see actually that the donation rates already dropped after 2018. And undeniable, COVID didn't help to improve the numbers, but nevertheless there was already for some countries a decrease of donation reported in 2019. Well, looking at the organs transplanted, there was a drop of 9%. If you have 10% less donors, this is more or less than in line with it. But still, we managed to exchange 21%, almost 21.4% exchange between the Eurotransplant countries. This was similar to 2019, where it was 21.3%. So let's focus to the COVID period, March-December 2020. And here we have, in this graph, the cumulative transplants from March 1 till December 31, 2020, compared to 2019. The orange line is 19, the blue line is 20. And here you see the effect after the first wave of COVID. There was a decrease, and actually you see the same effect in starting already in October until December, that there was another decrease, probably caused by the second wave of COVID. However, if we compare the number of percentage transplanted organs, 19 versus 20, still the same. The blue ones are 19 and the orange ones are 20. You see that actually the use rates of these of the donor organs transplanted was more or less the same. We have a small decrease of kidneys being used in 20. We looked into that, and we saw that it was a decrease of the use of extended criteria donor kidneys. This explains the decrease. Last, what we looked at was the number of closed programs, which you can report in the Eurotransplant system. And you see that in March last year, we had almost 40 programs, mainly kidney pancreas programs and living programs were closed during the first wave. And then after the first wave disappeared a little bit over the summer, you see that the number of closed programs drops under 5. Then in October, you see the first signs of the COVID pandemic, of the COVID infections increasing, but not so huge as it was in March. And still this graph goes up to March this year. You see that the programs more or less stayed open. However, we still see that donation is at a lower level and transplantations also. Then, last but not least, this is the website of Eurotransplant, and since the beginning of the COVID pandemic, we asked all our member states to provide us with the web links of the most recent information on their COVID regulations and restrictions, and this is published here on our website altogether. So if you want to have a look at it, just go to our public site and look for COVID-19 information, and you will find all the regulations in the different member states. That's it for me. Thank you very much.
So thank you, Serge. And now, if you have any question, just post in the Q&A box, and I'm going to introduce the next speaker. Ivan Kneževic, he is the, sorry for the pronunciation, is the director of the Transplantation Center at the University Medical Center in Ljubljana, Slovenia. And is the chair of ECTTA in ESOT and a member of the Thoracic Advisory Committee of Peri-transplant. Ivan will talk about COVID-19 in donors and recipients, and he will tell us how we should deal with this new reality. Thank you.
Chairman, ladies and gentlemen, this topic is very broad and could be discussed for sure for hours, but due to the time limitation, I will only highlight the key issues. So I have no conflict of interest to declare in connection with this lecture. You're welcome to share details of my presentation. So we already heard, but the effects of COVID-19 on organ transplants have profoundly affected potential donors, candidates, and recipients, and declining donations and the pressures of limited healthcare resources from pandemic disrupted transplant systems. The impact of declining organ donation and transplantation on outcomes is extremely significant and difficult to assess. So what I'm going to talk about, first, donors, candidates, and recipients have to be universally screened and tested for COVID-19. We have to know that negative initial testing do not absolutely eliminate the possibility of infection. Continuous monitoring and testing protects not only potential recipients, but also healthcare procurement teams and prevents the transmission of viruses between facilities during procurement. A non-urgent transplants in recipients older than 65 years who are at greater risk for severe COVID-19 should be put on hold, and living donor transplantation have to be rescheduled. Probably vaccination should change it in future. Peri-transplant period. We know that the infections in the peri-transplant period have a higher morbidity and mortality than infections in long-term transplant patients. That may be directly related to intense immunosuppressive drug regimens, including induction therapy. The absence of infection derived from donors should not be viewed as a low possibility of transmission, but rather a success of preventive measures. In organ recipients infected with, we have to know that in organ recipients infected with SARS-CoV-2, a longer duration of PCR positivity may require a longer duration of isolation and testing to reduce the risk of transmission. Management of COVID-19 in transplant recipients. Here is the timeline of SARS-CoV identification, with the yellow line shows the cumulative number of cases, and there are also shown selected announcements and therapeutic milestones related with COVID-19. What about the antiviral measures? Antiviral drugs for SARS-CoV-2 were chosen based on data obtained during the SARS-CoV-1 and MERS outbreaks or in vitro activity against SARS-CoV-2. It should be noted that no single agent has proven to be successful and had reproducible results in long-term trials. Most research agents are corticosteroids, remdesivir, tocilizumab in ICUs, and convalescent plasma. The most promising antiviral drug for sure is remdesivir, and it showed a significant reduction of time to recovery, predominantly seen in patients needed oxygen. Also, that was shown in Solidarity trial. If it was given early after the infection onset, it was helpful in reducing the viral load and avoiding the development of the cytokine storm phase in patients who may have a risk factor for a worse outcome. Administration of convalescent plasma was useful for also reducing viral load and time to clinical improvement, also if it was used very early in the early phase of disease. Several highly active monoclonal antibodies against SARS-CoV-2 and are under evaluation, and also anti-spike neutralizing antibody in reduction of viral load in outpatients with COVID-19 phase 2 trial. They're under evaluation. Okay, what about the immunomodulatory therapy? We know that the second clinical phase of COVID-19 is characterized by the release of inflammatory cytokines and coagulation factors. And so several studies assessed whether inhibiting elevated interleukin-6 by blocking the interleukin-6 receptor with tocilizumab could have beneficial effect, but that was shown that it was not associated with the reduction of mortality. Steroids should be used in all patients with COVID-19 who need oxygen or mechanical ventilation. Increase in organ recipients, increasing the dose of prednisone or adding dexamethasone as part of the modulation of immunosuppressive therapy may be recommended in case of advanced disease. Clinical trials are currently testing some other immunomodulatory drugs, but they are still under evaluation. So what about the immunosuppression management? The primary aim of immunosuppression management in recipients is a balance between the risk of rejection and complications of over-immunosuppression, such as worsening of COVID-19 complications and superinfections. But the complete withdrawal of immunosuppression is not recommended. Thus, cautious reduction rather than complete elimination of immunosuppression may avoid precipitation of severe complications like ARDS. What else we got from COVID-19? Yeah, we found there is a growing interest in transplantation for end-stage COVID-19 induced lung disease. The first cases were reported in China and Austria. According to the available literature, about 20 cases have been published so far. 2 of similar transplants were also performed in our institution, one acute on a patient on ECMO support for 2 weeks, and one other for the severe pulmonary fibrosis after the severe pneumonia, COVID pneumonia. A careful definition of the clinical indications and long-term results is needed to determine when to consider transplantation as treatment for end-stage COVID-19 induced lung disease. And now some Slovenian data. You already saw that we were lucky last year in 2020. We had even more donors than in 2019, probably also due to the high concentrate for donation. Usually last years we have that between 75 and 85%. And due to that, we were able to even increase the number of transplants in last year by almost 20% comparing to 2019. So these are our Also, our data after the transplant, 11% of all the transplanted patients confirmed SARS-CoV-2 infection. Half of them were hospitalized, and that is very similar to the published rates. 7% of them admitted to ICU. It was published there from 8.6 in the Netherlands to 18 to 34 in other cohorts. But we were lucky, and only 3% of our patients died. All of them were after the kidney, long-term after the kidney transplants, and that was 3%. Mortality, according to the literature, was between 9 and 46%. So for the future, what the transplant program need to do? First, to individualize their approaches with prioritizing the patients requiring transplantation, selecting which organ to accept local donors better, avoiding travel to the procuring team, and minimizing delayed graft function to reduce hospital stay. And then televisits, we already heard about that, for stable outpatients, and balancing the risk of excessive immunosuppression against allograft rejection. And so we found there are some new challenges, and one of them is unclear efficacy of current investigational therapies, a lack of data on optimal immunosuppression management, delay in vaccine deployment, and new ethical dilemmas. So in the end, my message at the end is keep our transplant programs running and give our patients a chance to survive. Thank you.
Well, thank you very much, Ivan. Quickly, I think it was interesting to see your final message about the avoidance of delayed graft function. I've already seen a question, but I'll leave it for the end to Serge. What was the rate of ECD usage? So probably this will answer also the question about EGF. I would like now to introduce our next speaker, because it's very important in the COVID-19 to look also at the patient. And Colin White, the National Projects Manager with the Irish Kidney Association, is providing us this overview. He served in this role since 2005 and has a long history in patient advocacy and the promotion of organ donation, inspired by his wife's
much, Colin, for this interesting talking that is from a patient's point of view. It's very rare to see somebody that is speaking from the other side of the problem. And so if you have any question, we have time at the end to answer. Please put on the question and answer box. And I would like to introduce our last speaker, Doris Segev, that is a professor of surgery and epidemiology and associate vice chair of surgery at Johns Hopkins University. He has published more than 500 peer-reviewed papers. He's a member of the National Academy of Medicine. And Dr. Segev will talk about vaccination in COVID-19, so which is a very hot topic during this time. Please, Doris.
Thank you very much, Doris. So I think we can now open to the discussion. I would like everyone to please submit their question through the Q&A. I've seen that someone has done this via the chat box. Please, we cannot keep track of this question in the chat box, so please do use the Q&A. I quite like also from Dori the initiative to recruit patients from the trial through social media. This really highlights the need to go over with social distancing, and I think social media really demonstrate this helpful role, particularly with the pandemic. The first question was for Serge about the ECD rate used during the pandemic. Was this the same before the pandemic, or did it change? And there was also a question from Franz Klaas that I acknowledge for his presence, that was still asking to Sergey, was mortality on the waiting list in 2019 due to influenza and in 2020 due to COVID? So there was this difference. Perhaps influenza did not have the same effect due to COVID. Thanks.
Well, thank you for the questions. And to start with the last one, thank you, Franz, for the very good question. Unfortunately, I'm not able to answer since the registration of the different causes of death is not very reliable. So I don't dare to say anything about the causes of death. We have a good registration of patients dying on our waiting list, but the reasons is a little bit weaker. Coming back to the first question, that was the use rate of the standard criteria versus the extended criteria donors. The extended criteria donors was during the COVID around 75%, and it decreased a little bit in 2020. So it could be COVID, but it could also be different causes that this rate dropped, the use rate dropped. We don't know. We just don't know. Standard criteria, the use rate of standard criteria donor stayed more or less the same at 92%.
Thanks very much. And I would like also to acknowledge the presence of Stefan Schneinberger, who is the Senior Advisor for Transplant Live, our ESOT learning platform. Thanks, Stefan, for joining us. He has a question to Dori. So, were there enough patients stopping anti-metabolite between dose 1 and dose 2 in order to indicate that stopping MPA-ASA would help getting a response?
Great. Thank you for the question, Stefan. It's a very interesting question, and something that has come up in many conversations with transplant centers across the US, right? So they're saying, well, if the anti-metabolites are really so harmful for dose 1, should we stop them in general while people are getting vaccinated? Obviously, there is the counter argument that if you are activating the immune system and you've disabled somebody's immunosuppression, you may also cause a rejection in those patients. So, it can go one way or the other. I know our field of transplantation has heterogeneous opinions and very strong opinions. So there are certainly some transplant centers in the US that will probably stop the MMF in their patients, and we'll be able to gather data from them. Right now, we don't have data on anybody who has purposefully stopped MMF for the purposes of vaccination. But remember, our JAMA paper just got published last week, so its impact, however heterogeneous on the transplant population, we're not going to see for a little while yet.
Yeah, so
thank you. So a question from a patient, and then I'll leave it to you, about the vaccination in transplant patient. Was there any possibility that having then vaccine that is not an mRNA vaccine on kidney transplant patient could make no effect? This was from a patient in Ireland who is going to have AstraZeneca.
Yeah, that's a good question. We don't have AstraZeneca right now in the United States, so I cannot study this in transplant patients. We are just starting to get data on the Johnson & Johnson vaccine. So probably in about 2 months or so, we'll have pretty robust comparison between the Johnson & Johnson and the mRNA vaccines. I will say, and people ask this a lot as well, is it even worth it for transplant patients to get vaccinated knowing that the immune response is sluggish? And I will say, absolutely yes, unless somebody has a major contraindication to vaccination. First of all, by dose 2, we're already seeing more than 50% of people with antibody responses, and 50% is pretty good odds. I would take that sweet, Colin, if it had a 50% chance of giving me antibodies. And we don't know what's going to happen at 2 or 3 months. Sometimes the immune system is just sluggish, and we'll start to see antibodies at 1 month, and we'll see those rise for 2 or 3 months. And even if somebody does not have an initial response, we can't really predict who that's going to be, and you need to start the journey somewhere, right? I compare this to the journey of trying to throw COVID into the fires of Mordor, for those who understand the reference. And, you know, we need to start the immune journey. We need to start priming the immune system against this virus. And so I think that there's no better time than to do that now, again, unless somebody has a major contraindication.
Well, thank you very much. So, interesting discussion about vaccination. But what I would like to ask to Liset and Ivan is some practical advice or what they think about level of evidence in COVID-19 and what's the study are and what we should have in terms of future study to provide this evidence for a priority of patients in the waiting list. So who should we transplant? For example, there are some very early stage systematic review and meta-analysis that seems showing that risk factors for mortality in recipient are more or less the same as general population. Is a true message? Is something that we need to investigate? And then modified attitude. And for Ivan, you said that you will decrease antimetabolite by 50%, right? It's something empirical that you base on your own experience, or what's the advice for other transplant centers? Thank you.
If I address the question that you asked, so the studies that we sort of analyzed all sort of consistently showed that age is an important risk factor that is associated with mortality, and I think there is still a lot of data, more and more data coming out, and that we need to wait a little longer until we can sort of have more robust evidence to see what other risk factors are important.
Okay, Ivan?
Yes, thank you. I mean, this is a moderate disease, as I said. It is but I can say we are relatively small. I mean, we are the only center in Slovenia. You know that Slovenia is a small country, so we're performing a limited number of transplants. And probably, I mean, our experience is probably very hard to say to be the worldwide experience, but this is something to be it was discussed, and this is some kind of as I know, European opinion. I don't know how it's in Italy. You don't reduce antimetabolites?
Well, our policy in the center is it's basically to reduce the antimetabolite, but for patients that are at risk. So all the old patients, so more than 60, 65 with comorbidities. So that's what we do as a prophylactic action. Obviously, if there is a COVID-19 positive patients in the recipient, we just stop antimetabolite and carry on.
But as I said before, we hospitalized like 50% of the positive patients, and in that group were all the positive heart transplant patients and all the positive lung transplant patients. But we haven't lost any of them at the end. Okay, we have no problem with one lung transplant patient with a terrible outcome due to COVID-19 pneumonia. That was not that one we transplanted due to the COVID disease. I can't say if that approach is the proper one. At the end, you saw that we lost only 3% of the patients. Maybe we started also with plasma and remdesivir. I don't know which is the proper way. It's very hard to, as you asked before, to study because so many factors are influencing the result and numbers are small. So I don't know.
About the lung transplant, unfortunately, there was a report of transmission of COVID-19 actually from a donor to recipient, and it is fatal. Yeah, so I think this is really something to think very carefully about.
Yeah, there was one published case, yes, of the transmission.
Yeah,
because it
exactly.
was very deep. the virus was very deep in the lungs, but so
well, and also the healthcare professionals actually got infected. So still, this is an issue also for those who work
I agree.
with this. There are so many questions that are coming. I would like also to say hello to Frank Dorr, who is listening to us, and he has put down a similar question to that of Franz Klaas that again I acknowledge. So there are patients with de novo DSA producing more often COVID antibodies than patients not producing DSA. This is a question about the immunology risk. Maybe someone, probably Dory, what do you think about the immunological situation in patients?
Yeah, I think if this is Franz Klaas's question, assuming it was with the vaccine response, we are collecting blood to look at DSA in patients in our vaccine study, but we have not had a chance to analyze any of that yet. So I don't know at all the relationship between DSA and vaccination. I can imagine that people who have more active immune systems might have a better response to the vaccine, might also be DSA makers, and the vaccine, because it causes, some sort of immune activation. We know inflammatory events cause upregulation of donor-specific antibody. It may be that DSA is upregulated in people who receive the vaccine as well, which could be one of the risks of the vaccine, particularly in patients who are pre-transplant, receive the vaccine, and then go in for a live donor transplant or a deceased donor transplant later. We have been checking DSA, rechecking DSA on them after vaccination.
And do you plan also to make some studies on T cell and B cell? I heard you are getting in touch with the lab because there are questions about how you measure the immune response, the cellular response as well.
Yeah, absolutely. So we're in the process of gathering blood samples. We have quite a few already, and our both our B cell and T cell immunology laboratories, which are card-carrying basic science labs that have a lot of expertise in measuring these. We're going to look at T cell repertoire. Our group already has looked at T cell repertoire in convalescent immunocompetent patients, and we're going to use what they've established of the expected repertoire and compare it to transplant patients, look at T cell activation, look at the cytokine production resulting from T cell activation, et cetera. So yeah, we're looking at a lot of the different immunological arms of this.
Thanks. There are a few questions, about the living donation, whether a living donor is a higher risk. Someone from the panel wants to answer this question. Is there any study published or any personal experience? Dory? What do you think?
I think I saw one brief report somewhere. I mean, there are 80,000 papers on COVID published. I can't remember where I saw it, but I did see one brief report in living donors, people who donated kidneys in the past who then got COVID disease and did not have appreciably worse outcomes than people with two functioning kidneys. There is some worry, of course, that we know CKD is one of the risk factors for worse outcomes with COVID-19. However, CKD is usually associated with a lot of other features that you don't see in living donors who have one perfectly healthy kidney. I would say, if anything, there may be a higher risk of AKI, which is quite common in people hospitalized for COVID, and that risk may be higher in living donors. But in general, I'm not familiar with any reports of particularly worse outcomes in living donors.
Thanks.
So I have a question for Colin. So Liset, she presented the paper about telemedicine, and she mentioned about this rural area in Italy where I'm dealing with. So I can confirm that there is a real problem in terms of communication in some area of Italy because people, they don't like to to use computer or other type of this instrument. So what's from your point of view, Colin, and from a patient's point of view about this telemedicine? Is something that is reducing the efficacy of the clinics? So what do you think?
I think anecdotally from listening to patients that the telemedicine is probably more appreciated by those who are a long time post-transplant and their transplant is settled, there's no anxieties, they're happy. Those who are maybe more recently transplanted still prefer the face-to-face. I think also there would be some concerns that, yes, you can address many things over the telephone, but for example, things like skin cancer, the patient may not pick up on it, but immediately, whereas a face-to-face with the consultant may actually pick it a little bit earlier. But I would say there's definitely scope for a hybrid approach in future, that quite a number of appointments could go to telemedicine.
So I think we are going to wrap up in a moment. Liset, do you want to add something that might be worth to talk about this?
In addition to the other topics that are discussed, you mean?
Yes.
Yeah, I mean, it was quite challenging to provide an overview of the emerging evidence in 9 minutes. But you know, the good thing is that now there is more and more evidence coming out on different aspects. So I think if we would do the same session in a couple of months' time, there would be a lot more to present again. So yeah, hopefully we'll get that opportunity. But within the working group, as you mentioned earlier, we'll keep working on it.
Thank you very much. And yes, I would like everyone to please visit our website, where there is currently update state of the art in terms of vaccination study, but we also have a forum that is open for interaction and discussion. You can post your questions and we will make them answered for you by our panelists offline. I would like now to ask you about this webinar. How do you think this was in terms of overall helpfulness? So we can launch the poll now. Was it extremely useful, fairly useful, or not useful? And I would like also to remind you that aside from our Transplant Live platform, we will host this webinar recording on our ESOT YouTube channel in the next few days. So please access Transplant Live, the COVID-19 forum, for further questions and discussion. Let's see the results of the poll. Well, fantastic. So more than 50% thought it was extremely useful, and the other half useful. So thank you very much, and goodbye.